afternoon, good evening. It is just past 3 o'clock in the UK, and I think it is just short of 9 o'clock in India. So we welcome you. Thank you for giving up your time to listen to us. It's quite late in the night. We'll try and make it as entertaining as possible for you. So I work primarily adult practices in Chesterfield Hospital. My pediatric shoulder and elbow practices in Children's Hospital, and I do some work for the University of Sheffield. I just thought I have the main talk that I have today is about total elbow replacement in trauma. Having been worked in India for so long, I understand trauma is a very important part of orthopedics in India, and therefore I think it's an important thing to understand what is a small but a definite indication of total elbow replacement in trauma. But I think before I start that talk, and excuse me if this sounds very basic, but I thought I'll just set the scene for what is total elbow replacement, what do we do in UK, just very, very simple things, 5 or 6 slides before I go on to my main talk. So people who are shoulder and elbow surgeons might think the first 6 slides is very basic, but please bear with me for the general orthopedic surgeons amongst us. So the primary indications for elbow replacement remains rheumatoid arthritis. We don't see as much rheumatoid arthritis in India, and primarily whatever arthritis we see in the elbow is probably osteoarthritis. Though having not been in India for the last 26 years, I'm not sure if the trend has changed. Of course, the trauma is different, and I will talk about the acute trauma and distal humeral fractures, but obviously post-traumatic arthritis, which is symptomatic, also forms an important part. In UK, we don't deal with tumors. They go to specialist tumor centers. And if somebody needs a custom-made prosthesis for a localized malignancy or a localized Mets, then it'll go from us to sort of somewhere like Birmingham for a tumor center. But I just thought I should put that on for you. Now, when I joined Sheffield rotation in the mid-90s, David Stanley was the consultant there. I was his registrar at that stage. And we were seeing a lot of this kind of x-rays. And I was quite amazed because having come from India a few years ago, I never saw this extensive arthritis where not only were patients in pain, but they had very limited mobility. And as you can see, this elbow, for all practical purposes, looks ankylosed. And we then found out the reason being the Sheffield was the steel making center of the country. And those days, in the lack of mechanization, there was a very high amount of upper limb and especially elbow involved manual labor. And people in their 40s and 50s were getting this kind of elbow pathologies. Obviously, nowadays with mechanization, we see this, if at all, in more than 60 years, they complain of pain and stiffness. And it is important to understand that not all elbows who look like this will be symptomatic. A lot of them will have limited mobility, but they'll cope because you as well know that only a certain amount of mobility, 30 to 130, is needed for functional use of the elbow. And therefore, please understand that if an elbow looks like that, it is not an indication for elbow replacement. More often than not, conservative options are okay. Occasional painkillers, you don't need physiotherapy for this, it doesn't help. An OK procedure is something I had never seen before I came to the UK quarter of a century ago, and it's a very effective procedure. And obviously, total elbow replacement remains your last option. Now, how do you decide when do you do an OK procedure? And I will describe what that procedure is. And when do you do an elbow replacement? So the way I say it, if you have end range pain, extreme extension and extreme flexion, then an OK procedure works well. Because all it does, it takes away the osteophytes from the front and the back. But if you have through range pain, where throughout the range of flexion movements you have pain, then I think OK procedure is unlikely to work because it's not just the front and the back which is a problem. Throughout the range of motion is causing pain. So I think that's a very simple tip to take away, which one to do: through range pain and end range pain. OK procedure is very straightforward procedure. You go from the back, you go through a tricep split approach, you excise the capsule, tip of olecranon and the osteophytes, then you create a hole from the back of the humerus to the front compartment and excise the tip of the coronoid, anterior capsule and loose bodies. Once somebody has shown it to you, it takes about 20-25 minutes to do. It's a very effective procedure in the right selected patients. And if you have ulnar nerve symptoms in the patient, you can do a cubital tunnel release at the same time. So this is a classic patient who has osteoarthritis. You can see a nice olecranon spur here. That's his native olecranon here. This whole thing is the spur. And in the front, you can see large bits of osteophytes. So you basically, in OK procedure, go from the back through the tricep split approach and remove all this. Then you make a hole from the back to the front. We use a trifine that we use for bone biopsies. And then you remove all the stuff from the front of the elbow. And the post-op X-ray looks something like this, where you can see the extra tip has been taken away, everything in the front has been taken away, and the patient gets reasonable pain relief. It's very important to tell the patient after OK procedure that you may not necessarily get a great deal of movement improvement, but you will get the end range flexion and extension impingement pain improvement. And this is something which a general orthopedic surgeon should be able to do. You do not need to refer it to a specialist center to have it done. This is the more common indication of arthritis in the elbow in UK. It usually comes in a young age, pain and stiffness. And the disease-modifying drugs these days are so good that we now see routinely elbows which are absolutely shattered and destroyed, but they have very little pain, in which case they don't need an elbow replacement. And radial head excision is not something we do in osteoarthritic patients, but in a select group of people, synovectomy and radial head excision does work. And if nothing else, it at least postpones the inevitable need for an elbow replacement. So this is a classic rheumatoid elbow, and the answer here is elbow replacement. I would not do an OK procedure in rheumatoid arthritis unless it's a burnt out rheumatoid resulting in osteoarthritis. So OK mainly for osteo, and radial head synovectomy as a stopgap for rheumatoids, followed by elbow replacement in both cases. There is a lot of debate which type of elbow replacements you should use and what kind of classification you should do, constrained, unconstrained. The way I was always taught was to say they're either linked or they're unlinked. And this is the one which I think Dr. Tiwari uses in India. And I think 75% of the elbow replacements that are done around the world are the Coonrad-Morrey elbow replacements. All three of us, myself, David Stanley, and Amjad, use Coonrad-Morrey elbow replacements. Unlinked are the ones which don't have a link in between, and Kudo was the old favorite. I have not a great deal of experience in Kudo, I must admit. And what approaches do you take? Tricep splitting, which is a well-known approach. Reflecting is better because it preserves the integrity. And I use, and most of our colleagues in UK for intra-articular fractures will still use an osteotomy approach. Myself and David Stanley wrote up a paper in 1999, British Journal, and we formulated this Stanley Shahane approach. And the big advantage of that, it combines the advantages of splitting and reflecting techniques. And I'm very pleased to say that a lot of UK centers now use this approach. And if you do want to read about this approach more in detail, then you have to just type in these two names and see 1998 British Journal JBJS. The advantage of this is that it protects the ulnar nerve, gives good exposure, and really provides a good tensioning for stability. I won't go into the details because that's not the topic under discussion today. And that is all. I want to set the scene in 5 minutes. We know what the indications for elbow replacements are. We know what other procedures we can do other than elbow replacements, and what approaches and how you classify elbows. I will now spend the next 8 to 10 minutes in describing elbow replacement in distal humeral fractures. Now, this will be very, very useful to even to primarily a large number of trauma surgeons in the UK. And India. Trauma surgeons in the UK who are not elbow specialists will still do this operation, but you need to be aware of the pitfalls, and Dr. Ali and Dr. Stanley will speak about it later. Please understand, if you have an intra-articular distal humerus fracture, the answer is not elbow replacement. The answer remains open reduction and internal fixation. There is no doubt. But once you do this, if you don't do it properly, or even if when you do it properly, numerous reviews have said the complication rate can be quite high. But this complication rate includes removal of metalwork, and especially the tension band wiring of the olecranon. And therefore, I think the complication rate has been skewed by removal of metalwork. And if you take the removal of metalwork out as a complication, to me, it is not a complication. But yes, it is a definite second operation. But we know that even if you do the best possible operation and use the best possible implant, the outcomes in elderly patients are not great for internal fixation. I'm going to show you a historical X-ray. This was one of the first patients I saw when I joined as a consultant nearly 20 years ago. And this is a straightforward distal humeral fracture. And this is how I fixed it then. I used recon plates, had some real struggle bending these plates. We had some headless screws here. I was still using this particular cancellous screw to fix the intra-articular fracture. And the patient had a good outcome. It doesn't look very pretty, but it did the job. And as you can see, I did an olecranon osteotomy. Now, if I have a fracture like this, my answers are not 90-90 plating. It's parallel plating. These are contoured. We follow all the principles of trying to get as many screws across as possible. But one part of my technique has not changed. I still do an olecranon osteotomy to get a good exposure, and I will continue to do that. And normally you would expect this kind of a range of motion. I think if done properly, you get one good shot at it, and therefore do it the best you can. But why is it a problem in the elderly? Well, Bone quality is poor. Usually when they fall, they really shatter the bone. There is loss of joint fragments. And some of them have pre-existing arthritis. And then some of them come with contractures and bony deformity. So this is not what you see in a 30-year-old who breaks his distal humerus. So therefore, what are our indications for an elbow replacement? The age has to be above 65. I prefer even beyond that, 70, 75. But sometimes you may see a 65-year-old who is physiologically older, has severe osteoporosis, and you think this fracture is not fixable. Don't try and fix it to convert it into an elbow replacement in 6 months. Take a decision right at the early, and I'll tell you how to make that decision making. So this is a comminuted fracture in an osteopenic bone, which is not amenable to stable osteosynthesis. And to me, this bit is an absolute indication. If somebody tells you that he had, before fracturing his distal humerus, in a lot of pain because of pre-existing inflammatory joint, then don't try to fix it. Because that joint would not have been mobile before. You're trying to fix immobile joint, and the transfer of forces will happen across the fixation, which at best is tenuous in an osteopenic bone. So I think that is a good indication for a primary elbow replacement in distal humeral fractures. What are the contraindications? Please don't replace an elbow replacement in a 27-year-old. He comes, send it to somebody who can fix it properly. Compound fracture, poor skin condition, active infection, obviously you wouldn't dream of doing anything there. Olecranon fracture is a relative contraindication because otherwise the proximal ulna has no support. Though you can fix the olecranon and replace, I have no experience in that. And I wonder if my other co-authors have any further experience in that. What are the type of prostheses? We have just told linked prosthesis. Why do we need a link? Because these fractures have a lot of bone loss and they have lost two important stabilizers. They have lost the static stabilizers, which are the ligaments, and there is a significant damage to the muscles. And therefore, inherently, they have very little stability of their own. And therefore, you need to put a link in between to provide the stability due to the lack of these things. And the prosthesis of choice for us is this Coonrad-Morrey prosthesis, and that's the link we are talking about. So that links these two and provides the stability, which is axial and varus valgus stability. It allows early mobilization, and this anterior flange that you can see provides rotational stability. It does not disassemble and is very user-friendly. Once you get used to it, a straightforward operation is not difficult, trust me. And it has very, very good results in long term. You can see these bushings here. They can get worn out though. Polyethylene bushings can get worn out. And sometimes you will just go into a bushing replacement. So what are the preoperative conditions? Before you take a patient to theater, please decide whether you're going to do this or you're going to do this. Fix it or replace it. Because normally these are difficult fractures and therefore you're going to do an olecranon osteotomy. If you do an olecranon osteotomy, you don't want to be doing an elbow replacement. So don't say, I will decide this intraoperatively. Normally, I will say, get a CT scan done, discuss with your colleagues and decide which way you're planning to go. Look out for a supracondylar extension and be careful that you have all kinds of lengths of humeri available if you want to bypass the supracondylar extension. Please be aware, if there is a shoulder prosthesis and the tip of the stem is coming down, that you don't reach halfway through and say, oh God, I've hit the stem in the canal. I can't go any further. And please look out for canal diameter. Especially in India, Asian ladies will have very tiny medullary canal. So be very, very careful that halfway through the operation, you don't reach a stage where you can't put the humerus or the ulna inside. So be aware of all of these things before you embark on the surgery. These decisions have to be done before you enter the operation, not during the operation. The technique we use is lateral decubitus, central midline approach. We always decompress the nerve. We don't routinely transpose it anteriorly like some of the Americans do, and we use our own designed approach. It's very straightforward. I'm just putting it in one line. You basically excise the entire distal humerus and bend it and put the humeral and the ulnar components. We always use the cemented humera and the cemented ulna. Post-operatively, I have started putting elbows in extension because the big problem here is the skin condition of the olecranon is not great. And if you put it in flexion and the immediate vascularity of the skin goes, then you start getting a little bit of a dehiscence of the wound, and then that becomes a superficial infection, then it becomes a deep infection. It is just not worth it. Let the elbow heal. Getting mobility in a linked elbow is not a problem. And then start gentle flexion with extension night splint for the next couple of weeks. Discard the splint in 2-3 weeks. Once the stitches are out, the wound is healthy, you can go for the physio. These are my requirements, and we normally say to people that once you've had an elbow replacement, to increase the longevity of elbow replacements, don't carry more than 5 kilograms of weight at one time or 1 kilogram repeatedly. Try not to use crutches, easier said than done. Don't use body weight on the elbow, and golf can be a no-no because it transfers a severe amount of stress during especially the driver phase anyway. These are complications. I don't want to go into this. This will be dealt by my other two speakers. Review of literature. So Morrey's clinic produced this first paper in 97, where they saw 20 patients, mean of 72. They followed them up for up to 10 years, and they were really, really good outcomes because they had selected the patients well. And then there is a lot of literature that is available. Joe Garcia is one of my colleagues in Chesterfield with David Stanley in UK, produced their first experience in 2002, and they had very good outcomes. All the three UK authors, I'll come to that in a second, the Canadian Orthopaedic Association then produced these results again in October 19, which were very favorable. And all of us three authors then wrote this paper in Journal of Shoulder and Elbow Surgery, and we had 26 consecutive patients. Look at the age range here with community distal humeral fractures, and at 5 years, we had very, very good outcomes. This is something that was fixed and sent to me. I could see this was not going to work, and predictably, it went into this, and I think the elbow replacement was the right answer. This was in my very early days, and you can see this length is not enough, and there is a huge supracondylar extension, and this prosthesis failed. And I had to then revise it to a long stem. It was a real salutary lesson to me why this supracondylar extension that I was talking to you about is very important, because there is very little stem beyond it. So just be careful of this. Now, if you see this in a rheumatoid patient, completely shattered, it is beyond me to fix this. You can, but I think it will fail. And therefore, I have no objection in doing this as a primary replacement. This particular patient developed a lot of myositis, which I think Amjad and David will speak about, and eventually lost some movement, but she was very, very happy with the outcome. One operation that gave her independence back to her. And I will finish on an amazing case. This is a 78-year-old lady who came to my clinic in 2017. She didn't directly come to me. This was the kind of fracture she had. And my colleagues, I was on holiday, treated this in a brace for first 6 weeks. There is zero chance of this healing. And then at 3 months, they continued, and no different, exactly the same. And this lady had rheumatoid arthritis. You can see the joint space really narrow, poor elbow function before. And to me, this is the definitive answer for her. A really long stem, and I've not done the same mistake. It's coming till here. I've gone overboard completely. I've said, let's neutralize the entire humerus. This is one of my happiest patients because you have given her life back because she had a pseudoarthrosis halfway through. So total elbow replacement is a good option. It is a very appropriate patient selection. Be careful of what can go wrong. Use good surgical techniques, but please remember, it is not an answer for everything, and internal fixation remains the gold standard. Thank you very much.